Yeah, so I'm a neuropathologist here at the University of Washington, and I've been here, I guess, almost 6 years, not quite, it's more like 5.5, and how I ended up here is I came to be part of the brain bank and do research here and be a clinical neuropathologist. So what is a clinical neuropathologist? That might be something, sometimes other doctors don't even know what a neuropathologist is. So we are doctors, but we interface more with other doctors who care directly for patients. So our main job is actually looking at the tissue that like surgeons get out and making diagnoses. So most often that comes in the form of making a diagnosis about brain tumors, but anything that people could have in their head would be something that we would make a diagnosis on. So it doesn't even have to be a tumor. It can be an infection or an inflammatory disorder or lots of other things. Well, that's, I guess, a little bit of a long story, but after I finished training at UCSF in neuropathology, then I was trying to figure out what I wanted to do. Do I want to do mostly clinical work? Did I want to do research? Did I want to do a mix? And I decided in my residency that I wanted to keep doing research like I had done before, and so I was looking for a job that would let me do both a mix of clinical and research. And the area I decided to go into was traumatic brain injury, and that's because I wanted to do both electrophysiology but also use my neuropathology skills. And I was trying to decide what area of research would be best to do both, and I went to the neurotrauma meeting when it was in San Francisco, and I saw researchers doing both neuropathology and then some people also doing electrophysiology, so I thought, well, this area seems to fit with the two things I really enjoy doing. And so when it came time for getting a job, I really wanted to focus on institutions that were strong in the traumatic brain injury area. And Dirk Keene, who is the head of the division here, had really started pursuing collaborations with the local medical examiners and a lot of people studying traumatic brain injury so that we can bring in people who have died who have traumatic brain injury and look at their brain tissue. And so I ended up coming here because I thought this was the most interesting place in my country to be able to study that. Yeah, so I always liked neuroscience for the longest time. I think what solidified it was reading a book from the library when I was like 10 about how dreams work and like going through the different sleep stages and talking about things like that. Mm-hmm. And so after that, I got really interested specifically in neuroscience and, you know, had like a brain coloring book when I was 11 and just always enjoyed it. And then when I went to college, I actually, I liked lots of things in science. So I started out as a chemical engineer, and I always I knew I was going to go to med school because I just thought that would be the most useful way to use my skills in science. And I was planning on doing like a minor in neuroscience. And when I talked to the advisor in chemical engineering, they were pretty negative about doing engineering and going to med school, which was a little surprising. I wish I hadn't listened to that as much because I think a lot of the skills used in engineering are actually, I wish that I knew more of now. Anyways, I decided, well, fine, I won't do engineering then, I'll just do neuroscience because I always have liked neuroscience. So I did my bachelor's in neuroscience, and I knew I was going to go to med school, but then I happened to see a random pamphlet somewhere about the MD PhD program. And I'm like, well, I really like research too, so I'll just do both. And applied, and miraculously, I don't know how, ended up getting in at the University of Chicago and ended up continuing on doing med school and graduate school there in neuroscience as well.
Very cool.
And then how I chose neuropathology. That was hard. That's also a long conversation. But I guess I had thought going into med school I would be a neurologist or a neurosurgeon or something like that. And I didn't know much about neuropathology. So when I did my neurosurgery rotation, you know, that one was, you know, people weren't sleeping hardly at all, which didn't work for me because I need sleep to function. Thank goodness we have some people out there who don't seem to need it as much. Neurology I really liked. That was really cool. But then I happened to work with neuropathology as well, because part of my graduate school we did recordings from human brain tissue that came out of epilepsy surgeries. And so we'd always have to correlate our data that we got on this human brain tissue with the pathology. And so I got to know the neuropathologist who was looking at the brain specimens and decided to look more. And we actually had a lot of pathologists teaching us some of the disease classes in med school, and I ended up doing a rotation in neuropathology. I just liked the day-to-day of looking through the microscope and the cases where no one knew what was happening to the patient. Eventually they would get a brain biopsy, and those always to me seemed like the most interesting cases. So even though I really like neurology and interacting with patients, the day-to-day was more interesting, going and being a neuropathologist and actually looking at tissues and doing autopsies. And so that's how I ended up going into that instead of neurology. I think we're still getting there when it comes to what we're doing. Leah is learning to patch right now in my lab, and I think exactly what we're studying right now, we're still trying to understand what's happening with traumatic brain injury, because no one really understands the things that happen and lead to the chronic outcomes, partially because people haven't really studied chronic traumatic brain injury, I think, for a while. A lot of people have focused on the more acute events that happen right after severe injury, and for a long time I think that it was thought of, oh, you have an injury, there's some healing process, it might take a couple months, and then whatever's healed is healed and you go on with your life. But it turns out that's not the case. Having a traumatic brain injury sets you up for a much higher risk of neurodegenerative disease later in life, but we don't really understand why that is. So my lab is really trying to understand, well, what's happening not at the acute phase, but that sort of chronic phase where things keep progressing and we don't understand why. And I think at this point we don't have something that's a direct answer to be able to help people, but
not yet.
We have a lot of interesting findings that have to do with neuroinflammation is one area that we focus a lot on, and how the microglia and the astrocytes change, and they remain changed and keep changing, that I think we might be able to have therapeutic targets from if we understand that a little bit better. And then we also see that some of the inhibitory neurons that are dying in Alzheimer's disease are also dying in the early stages of TBI. So we're trying to understand what the similarities are and if that might set the brain up for an increased risk after a traumatic brain injury because of the similarities. Well, I think I enjoy both worlds, but you're always a little bit in both worlds, and you have to be really good at going back and forth. I think what makes me a little bit different in the way I approach research is because I have a little bit more of a general background, and I'm always trying to take sort of what I see in slides and then relate that to my research, and then take that to like a mouse model to try to understand better, versus someone who's just doing research doesn't have that same I guess background of the day-to-day looking at slides and human brain tissue and like seeing the reaction in human tissue. And so I feel like me having that experience helps me target things in a different way that the other people in just doing like a PhD only maybe wouldn't have that opportunity to give them ideas for how they do their research. Yeah, I think that can be tricky. I think you really, really have to love research in order to consider doing an MD PhD program. And you have to also really love the clinical side of things. It is a very long road, so if you're not sure, I would maybe encourage people to focus more on one or the other. But in the long run, I feel like I ended up getting my dream job because I get to do both, and that really excites me. But it took a long time getting there, and along the way, you start med school, and the people I started med school with were in charge of me by the time I got to residency, And then the same thing with, you have to do more research after you finish your residency and do a postdoc really before you become faculty, and so people pass you by again. And so I think it can be really discouraging if you weren't, 100% into combining the two. And you can do research as an MD only. I think it's just a little bit harder, and it's hard. It takes time to learn the skills, and there's still ways to learn them, but it might just be a little harder, and you have to be a little bit more focused on what skills you're going to gain versus doing a PhD. You have a little bit more flexibility to learn a lot before you hone in on exactly what you're going to focus on. So it's complicated. I'm happy to talk to anyone thinking about that decision. You definitely have to have the passion to do both to make it work. And then research only, I think, is of course pretty cool, but it's harder. I've always been very translational, and probably because I always wanted to go to med school. So I feel like it's harder to really focus on some of those more translational things in human disease without knowing a lot about human disease. And so having that medical background is important. There's ways to learn that as well, but it just makes it harder for you if you wanted that focus. Yeah, so a microcircuit, I guess, it's a terminology for sort of it's thought to be sort of the building block that makes up the cortex. And so a microcircuit is sort of thought to be one little circuit that controls the information flow. And those little microcircuits are all hooked up together to make all of the cortex. And so I guess I always thought trying to understand how information flows and how the circuit in general is functioning is interesting. And so the mixture of the different layers where information goes and then how the inhibitory neurons feed back has always been something I thought important for processing. And it makes it sound very simplified to put it like that. Totally. We certainly don't understand it so easily, but that's the general idea, is that there is this precise way information flows with neurons not being too hyperexcited or too quiet, and everything has to work together in concert. And so I think it's really interesting to think of the cortex working like that and what stops that from happening, whether the proper inhibitory neurons aren't there, or whether microglia are overly activated and taking away the synapses and things are too quiet or too hyperexcitable is sort of the focus I am thinking of. And then we all know that bad activity over time can lead to things like epilepsy and just circuits not working properly, so then that flow of information is no longer happening. Essentially, I'm always interested in the activity of neurons and how that relates to injury and how injury affects it, and how they go back and forth between each other. It's always challenging to understand. I think you have to choose the right model for what is important for human disease, right? And so depending on what aspect of human disease you're looking at, a mouse model may or may not help you with that question. So when it comes to the work in traumatic brain injury, of course we can produce a focal injury pretty well in mice. They do have a neuroinflammatory response with some of the properties of microglia being shared between the two, so I think that's useful to look at. But if you were wanting to look at white matter shear injury from the head rotating in space, microglia, the white matter in mice is totally different. There's a lot less of it. How their head moves in space is totally different. They don't have gyroid membrane. So I think if you wanted to understand that a little bit better, that wouldn't be the best model. So I think you have to think carefully about what you're trying to look at in your models and make sure that that's the right model to be doing something. I think you're always going to have disagreements at some point as you're learning, because as you learn to be good at being an expert at something, you have to learn to question things in science and in medicine. And so at some point, you're always going to have a disagreement, even with the people who trained you. And so I don't think it's ever come to a horrible disagreement that has led to an end of a relationship or anything. But I think that's part of why they were good mentors, is that they taught me to question things, even if it was coming from them. And so being able to bring that up in a respectful way, whether you disagree with, are we sure about this diagnosis? Could we maybe consider this other test? Or staying to look at the tissue before we finalize this? Or in research, is this really what's happening here, or could there be something else happening here? So I think in general, there's been many instances where you just say, well, let's take a step back, whether it's in research or in medicine, and discuss this a little bit more before we finalize. And I think that's always led to a good outcome. Good mentors will not be upset with someone questioning them. Yeah, I mean, I think that's important I'd say that's probably one of the best qualities of being a physician scientist, is you should be able to question. And so having mentors that encourage that and didn't get offended if they were questioned. Well, on the clinical side, there was actually one person who was diagnosed with a brain tumor when I was on the neurology service. And so, and I was there the night she was diagnosed and sort of heard her story, and she was a bit in shock. She actually thought that the symptoms she was having, she thought maybe it was because they had finally gotten pregnant, and of course, when it turned out not to be pregnancy, but in fact a brain tumor, it was really devastating. And so I think seeing her reaction and just seeing a little bit of what she went through really changed things for me. So when I'm on that other side right now making these diagnoses, I know a little bit what it's like for the patient. And that can be really hard sometimes. I actually think it's important that I'm not the person directly talking to the patient, because then I might look at the slide and not be able to say how bad this really is. You have to diagnose a really bad brain tumor that someone might die. You need to be sort of unbiased in that, and if you know them and really want the best for them, it might be hard to make that diagnosis without being oh, maybe that's not really there. Maybe we can make this better than it is. And so I feel like having that experience made me realize that I think it's really important for there to be different types of doctors doing different things. If that makes sense. I don't know if this is totally answering your question, but I just remember this experience and then thinking about how I diagnose things later. It's good to be a little bit separate because of the emotion that you as a physician have in your interactions with people. At least in neuropathology, we're making the diagnoses and calling out the tissue, what's on there, and that's separate from the neuro-oncologists who then tell the patient. And I think, to me, seeing that case happen in real life, it was sort of important to have that extra step in there. Well, I think that was more related to a brain tumor, and I focused more on traumatic brain injury. So I guess it didn't directly affect how I do research, but it certainly affected what I think about when I question if my day-to-day in the clinical service isn't doing anything. I know that it is because I've seen it. And
more of the physician work.
Yes. Mm-hmm. But who knows? There might be. I study brain injury in many ways, and tumors are also damaging the brain. So there are ways I might end up doing research in that area someday. I hope that we find something that ends up being a clue to try to understand what's happening in traumatic brain injury. So that's, of course, a big goal, and I think everybody hopes that their research leads to something that will change life for patients. And how we're going to get there, I think, can be sometimes hard to see because things are so multifactorial. But I'm really hoping that one of the things we find with either the satellite microglia or the inhibitory neurons ends up being something that we could actually change in people that would lead to something better. But in the immediate near term, I just I hope people who have traumatic brain injury have a little hope that things aren't just going to stay this way forever, and there's a lot of people who are interested in finding, something new. And everyone, every year, new people come into the field, new ideas, and I'm sure, 15 years from now, there will be something much different than there is now. And then I guess that brings up why I think mentorship is so important, not only because, first of all, it's just great to always be involved with people who are new to the field and are excited. I think excitement's really important in research, and so always having, new young people come in and contribute can really change an entire lab's perspective on work. But they also come in, they have new ideas, different backgrounds. That is going to, I think, be really important for some of the major breakthroughs that are going to happen someday. And so being able to contribute to that and directly to where their life goes, I think is really cool.